Good evening, ladies and gentlemen. My name is Dr. Aurangzeb, and today we will discuss myocarditis in a nutshell. We will summarize the whole topic in 5 points, starting from introduction, etiology, diagnostic workup, clinical presentation, and finally treatment. If you are new to my channel, I will request you to please subscribe to the channel and press the bell icon so you receive notifications about our future videos. Also, if you have any questions and any queries, please write them in the comment sections below. So let's begin our lecture. We begin our lecture with the 5 points, and these are etiology, clinical presentation of myocarditis, what are the physical examination findings, how will you work up such a patient, and what is the treatment. Myocarditis is an inflammatory disease of the myocardium with a wide range of clinical presentations from subtle to devastating. It usually manifests in otherwise healthy person and can result in rapidly progressive and fatal heart failure and arrhythmia. Recently, myocarditis has been associated with COVID-19 and to a much lesser degree linked to messenger RNA vaccines against COVID-19. When we talk about the etiological factors of myocarditis, this is a long list. I will not go into the details of the etiological factors, viruses, and we know that viral infections are the most common cause of myocarditis in the developed countries particularly. Viruses responsible include the SARS coronavirus, enteroviruses, Coxsackie B, adenovirus, influenza, cytomegalo, poliomyelitis, Epstein-Barr, HIV-1, viral hepatitis, mumps, rubella, varicella, variola, arboviruses, respiratory syncytial virus, herpes simplex, and a long list of viruses can cause myocarditis. Some of the offending drugs include the chemotherapeutic drugs, certain antibiotics, antihypertensive drugs, anti-seizure drugs, phenytoin in particular, amphetamines, cocaine, and catecholamines, chemicals such as benzene, carbon monoxide, rickettsial causes, bacterial causes, physical agents such as radiation and systemic inflammatory disease, and a long list of other etiological factors. In this slide, the clinical presentation of myocarditis will be discussed, and patients with myocarditis may present with mild symptoms of chest pain in concurrent pericarditis. They may have fever, sweats, chills, and dyspnea. In viral myocarditis, patients may have a history of recent, within 1 to 2 weeks, flu-like syndrome of fevers, arthralgias, and malaise or pharyngitis, tonsillitis, or upper respiratory tract infection. Adult patients with viral myocarditis often present with chest pain, arrhythmias, and dyspnea. And their viral signs are typically abnormal and include fever, tachycardia, tachypnea, and hypotension. Physical examination of such patients usually presents with signs and symptoms of acute decompensation of heart failure. And on auscultation, there will be an S3 gallop, jugular venous distension. On general physical examination, peripheral edema and tachycardia may be present. In those with concomitant pericarditis, you may hear pericardial friction rub. Certain signs and clinical findings are specific to special cases. So if a patient has myocarditis secondary to sarcoidosis, these patients will have lymphadenopathy, arrhythmias, sarcoid involvement in other organs. Patients with acute rheumatic fever will have other signs and symptoms of rheumatic fever as per the Jones criteria, such as erythema marginatum or polyarthralgia, chorea, or subcutaneous nodules. Patients with hypersensitivity eosinophilic myocarditis have pruritic maculopapular rash and a history of using offending drug. Giant cell myocarditis, if is the etiology, and these patients usually presents with sustained ventricular tachycardia and rapidly progressive heart failure. Female patients with peripartum cardiomyopathy and concomitant myocarditis have heart failure developing in the last month of pregnancy or within 5 months following delivery. How we will work up such patients. So endomyocardial biopsy is the criteria standard for the diagnosis of myocarditis, particularly in the following conditions such as adenoviral or enteroviral myocarditis, human herpes virus 6 myocarditis, hypersensitivity myocarditis, eosinophilic cell myocarditis, checkpoint inhibitor related myocarditis, giant cell myocarditis, idiopathic granulomatous myocarditis such as cardiac sarcoidosis. And the Heart Failure Society of America recommends considering endomyocardial biopsy for patients with acute deterioration of heart function of unknown origin that is not responding to medical treatment. Cardiac enzyme, when they are elevated, they point cardiac myonecrosis. And cardiac troponin, that is troponin I or T in particular, is elevated in at least half of patients with biopsy-proven myocarditis. Cardiac enzymes may also help to identify patients with resolution of viral myocarditis, but negative troponin findings do not exclude a diagnosis of myocarditis. We can also check for antibody titers, but they are generally not required for the diagnosis of viral myocarditis because of its low specificity and the delayed rising of viral titers, which would have no impact on therapeutic decisions. Titers typically increase by fourfold in the acute phase and gradually fall during disease progression. Serial titers may be useful. Imaging that can be performed in patients with myocarditis include anti-myosin scintigraphy using anti-myosin antibody injections, and they can identify myocardial inflammation with high sensitivity and negative predictive power, but has low specificity and low positive predictive power. Gallium scanning is used to reflect severe myocardial cellular infiltration and has a good negative predictive value, but the specificity of gallium scan is low. PET has been used in selected cases, for example, sarcoidosis, to assess the degree and location of inflammation. And the final point is management. Most patients have mild symptoms consistent with viral syndromes, and they recover with simple supportive care on an outpatient basis with slow rehabilitation and the implementation of evidence-based medical therapy. Repeat assessment with echocardiography may be helpful to determine the persistence of cardiac dysfunction. Importantly, non-steroidal anti-inflammatory agents should be avoided in the acute phase of myocarditis, as their use may impede myocardial healing and actually exacerbate the inflammatory process and increase the risk for mortality. Talking about the definitive treatment of myocarditis, so it's debatable and largely depends upon the underlying etiological factor. But I will discuss what are the common treatment strategies for such patients, because these patients usually presents with acute heart failure. So the use of supportive treatment in the form of diuretics, in the form of vasodilators, either nitrates, nitroprusside, and inhibitors of renin, angiotensin, aldosterone system inhibitors are prescribed. Patients with severe decompensation requires inotropic drugs, dobutamine and meldenon, but care should be taken while administering these drugs because they are highly arrhythmogenic. And in patients with fulminant myocarditis and sinus tachycardia, always avoid the use of rate control agents, those with negative inotropic properties, including metoprolol, diltiazem, and verapamil. So don't prescribe beta blockers and rate limiting calcium channel inhibitors. Now also avoid the use of non-steroidal anti-inflammatory agents to avoid increasing sodium retention, myocardial harm, and exacerbation of renal hypoperfusion. Finally, statins may have a beneficial role in COVID-19 and have been shown to attenuate myocarditis, but additional studies are needed. Thank you so much. With this, we come to the end of our presentation. This was a concise and brief overview of a healthy topic, myocarditis. If you have any questions or queries, please post them in the comment section. And again, I will request you to please subscribe to the channel. Thank you so much.